Hello and welcome back to Obcast. Today we're going to talk about pregnancy of unknown location, a condition I'm sure a lot of the listeners manage frequently, and we're going to start things off with a case. So you have a 21-year-old woman. She's just done a positive home pregnancy test, and this is her first pregnancy. She comes in with vaginal bleeding, just a small amount, and some minor cramping. Her observations are normal. Her abdominal exam is unremarkable. She has some blood tests. Her hemoglobin is 129, her blood group's O positive, her HCG level's 900, and she has an ultrasound. Now this is one of the images from the ultrasound. This is a long section of the uterus on transvaginal scan, and it's reported as showing no evidence of intrauterine or extrauterine pregnancy and no free fluid. Now I'm sure this is something you come across in practice regularly, and this is what we call a pregnancy of unknown location. Now, as I've said, a PUL is a positive pregnancy test with a TV pelvic ultrasound unable to find the pregnancy. We see this a lot in our clinics, in our hospitals, and it's important we remember there's 4 outcomes of a pregnancy of unknown location. Firstly, it can be a normal intrauterine pregnancy that's too early, with the discriminatory zone of HCG being somewhere between 1,000 and 1,500 to visualise a normal intrauterine pregnancy on TV ultrasound. Or perhaps it could be a multiple gestation. It could be an ectopic pregnancy. It could be a failing pregnancy. And unfortunately, we probably won't be able to determine either intrauterine or ectopic pregnancy based on our assessment at this point. And the fourth entity, which we don't deal with commonly in primary care or the emergency department, is persistent pregnancy of unknown location, which we'll talk a little bit less about, but it can be spoken about at a later date. Now, pregnancy of unknown location, usually these patients undergo a risk assessment whereby you decide if they're significantly symptomatic, whether they have a lot of pain or bleeding, but most of them are suitable for discharge home, and they generally get serial Beta HCG levels, serial transvaginal scans. The timing of that depends on the HCG level and their clinical features, as well as close follow-up with return precautions to come back to or go to the emergency department if significant pain or bleeding, or if they're feeling very unwell. Now, observational data suggests if you take all women with a pregnancy of unknown location, 9 out of 10 or 90% can be managed without any intervention. So if they've got eventually a normal intrauterine pregnancy that is just allowed to progress, or a failing pregnancy of unknown location that the pregnancy can be expectantly managed. And about 10% require intervention, whether that be a suction evacuation or a laparoscopy. In terms of management, or at least, I guess, an ongoing assessment of a pregnancy of unknown location, really the initial step is a Beta HCG done 48 to 72 hours later. The concept is that in the early stages of pregnancy, on average, the Beta HCG level will double every 48 hours. Now, the numbers aren't quite as clear as that it's just an average, but it forms the basis of our ongoing follow-up of pregnancy of unknown location. Now, you can have a look at this table here, and I might demonstrate a few things. So, at 48 to 72 hours, if you do another Beta HCG level, and the rise is greater than 66%, which we consider significant, it's likely to be a viable intrauterine pregnancy. Now, of course, we need to be careful and tell these women to follow up with us closely and give them some return precautions as previously described. But these women will usually get a repeat transvaginal ultrasound in 1 week, and ideally when the Beta HCG level is well above the discriminatory zone. We'll go to the other end of the spectrum, and women who have a significant fall in their Beta HCG level are likely to have a failing pregnancy of unknown location. And these women need continued Beta HCG monitoring weekly until it's undetectable. But again, in the interim, close follow-up and return precautions. The tricky group fall in the middle, whereby they have either a small fall or an incomplete rise. And this is the group of women we think are highest risk for ectopic pregnancy. We know that ectopic pregnancies don't secrete Beta HCG normally and do so quite differently to a viable pregnancy. And therefore, we can use this, property to help risk stratify women into those who might need further investigation for ectopic pregnancy. So these women, they need repeat transvaginal ultrasound and ongoing serial Beta HCGs, but really a decision based on their clinical features, reliability, and the local capabilities of the service as to whether they should be either kept as an outpatient or an inpatient or even transferred if we're talking about a very small place. And the management options for pregnancy of unknown location with risk of ectopic pregnancy include ongoing monitoring non-invasively, endometrial sampling, or even a diagnostic laparoscopy. So I hope that explains how women with a PUL are generally processed in an early pregnancy clinic. I wanted to go a little bit deeper into serial Beta HCGs because they're very much used as black and white cutoffs, and unfortunately, as in most areas of medicine, it really isn't that simple. Now, the basis, as I've said earlier, is that a viable intrauterine pregnancy over 2 days usually rises over 66%. And this number has been used for a long time as a marker of adequate doubling or an adequate rise in the Beta HCG. The truth is, these numbers were taken from a study of 20 women who didn't present to the hospital or clinic with symptoms in 1981, and the level of 66% actually represented the lower limit of normal with a 85% confidence interval. So I guess statistically it's not a very strong number. There's been some newer studies in the 2000s, and one such study looked at 287 women presenting to the ED with pain and or bleeding, and they found with a 99% confidence interval the lower limit of Beta HCG rise for a normal pregnancy could be as low as 53%. Subsequent to this, there was an even larger study done with over 1,200 women, again symptomatic and presenting to the emergency department and diagnosed with a pregnancy of unknown location, that found there was even a woman who progressed to a live birth who had a Beta HCG rise of only 35%. Now, what this actually suggests is there's a bit of overlap between these groups in terms of the degree of rise of Beta HCG, and I guess that's going to reinforce our need to be clinicians and help clinically risk stratify these women as well as Beta HCG. I don't want to confuse the message. A normal pregnancy, on average, will easily double, and often it will increase by more than 100%. But whenever you're dealing with a patient with a rise at the lower end or just below what we traditionally consider normal, just understand when you're speaking to the woman or trying to reinterpret her clinical status that there is a lot of overlap between the group of ectopic pregnancy and live intrauterine pregnancy. We just discussed that a non-viable pregnancy of unknown location usually falls over 50% within the first couple of days. And again, this was derived from that initial study of 20 women. Now, a larger trial looking at nearly 400 women where some were evaluated retrospectively and then there was a prospective validation, found that in women with a HCG falling greater than 13%, it was highly likely to be a non-viable pregnancy of unknown location. And this was, quite sensitive and quite specific. Now, ectopic pregnancy has always been a difficult area with Beta HCG, and it's, I guess, a time to remember that women can present and have presented with ruptured ectopic pregnancies and beta HCGs of between 5 and 10, so below the threshold for urine testing and right at the lower limit of the threshold for serum testing. But when we're discussing pregnancy of unknown location, ectopic pregnancies, sometimes their beta HCGs rise and sometimes they fall, and it's pretty even as to which ones rise and which ones fall. Now, they usually fall less than 50%, and they usually rise less than 66%. So I guess you can see that, again, as we look into some of the greater studies, that there's a bit more overlap at the upper end of beta HCG rise. I've come to the end of what I wanted to say about pregnancy of unknown location. I hope I haven't added confusion about beta HCG doubling time. Although I think it's really important to have a deeper understanding of where our numbers come from and what levels of evidence and data suggest about how we can better make decisions about these women. So that's all I have to say about pregnancy of unknown location. I hope that was helpful. I'm sure you'll all see these women at work within the next couple of shifts, and thanks very much for listening.